rate, and there was some discussion on that during this forum. That probably gives you a better idea of the actual mortality, so the number of people who are infected in the community. Now, this number is not often known because what you know is who gets tested, and those are only those who get really sick or those who are able to access testing. So when in places where these seroprevalence studies have been done to look at the prevalence of antibodies in that population, it's clear that the number of people infected often is about 10 times the number of people who actually get diagnosed as cases, which is what gets counted. And so if you look at infection fatality rates, then that is a much lower number, and the figure that was presented was an average of about 0.6%, 0.6%. So that's much lower than the case fatality rates of 5, 6, 7% that we've been talking about. But again, this depends, again, pooling all the data that's still coming in from studies on the seroprevalence in communities will give us a better idea. But the bottom line is that there is a significant proportion of people who die, even if it's 0.7 or 1%, that's still high, and that it disproportionately affects people with certain risk underlying conditions, including obesity in young people. We have to remember the young people are not immune from severe disease or death. It's less common than in older people, but we should not become complacent that it's fine for young people to get infected, because there is a subset, particularly those with obesity, those with habits like smoking, for example, who are at higher risk of complications and death. So I think when we talk about death rates and mortality and we start comparing, it's really important to really look at how that's being calculated and before we do comparisons. The other thing we've seen is many countries have been able to update their death counts later, so it's not on a real-time basis. And but even in high-income countries, and certainly in the low and middle-income countries, the death reporting is not real-time. It takes time to catch up, particularly when people die at home in the rural areas. There's often incomplete cause of death reporting. So we have to keep all of those things in mind when we talk about case fatality rates, and especially when we start comparing between countries or between regions. Thanks. You want to add anything, Maria?
Thank you, Sumya. That articulated very well the challenges of estimating and comparing mortality. And as you've said, it's very difficult. It's a very difficult thing to calculate. I wanted to touch upon the question around the potency of the virus and the questions. We've received that question quite often, is the virus changing? And you mentioned the mutations, the changes. These are natural changes that we're seeing in an RNA virus, changes that we expect. And there's a large group of scientists that are part of this group that are looking at these viruses very, very carefully and looking at what these changes actually mean. We have not seen any indication that the changes, these mutations, these changes, confer any difference in terms of transmissibility and severity. But it is something that we are very carefully watching. And it's not just a matter of comparing the sequences themselves, but more work needs to be done to really understand the viruses and what these changes mean, if anything. And so I think that's just an important thing to add. And then just to mention on the serology, because this is part of the core work that we do within the EPI working group. And again, given we're 6 months in, it's pretty astounding that we have seroepidemiologic studies that are underway. And WHO is working in a number of areas with our partners in 3 different areas on serology. The first is to evaluate the serologic assays that are currently in development, and working with partners at FIND and other collaborating centers across the globe to look and see how well do these serologic assays perform against real samples. The second area of work is around what we call the Solidarity II collaboration, which is developing assays and having a panel to be able to develop a standardized serologic assay. And we have more than 110 collaborators from 43 countries in this collaboration. The third area of work is what we call our Unity studies, which is WHO has drafted these core generic protocols for 6 different types of studies on healthcare workers or on household studies or on cases and contacts. to support countries in conducting seroepidemiologic investigations themselves. And currently we have 45 countries that are actually implementing these studies right now, and we have an additional 34 that are intending to implement them. And so we're building research capacities, we're supporting countries in conducting these so that they could better understand what is the extent of infection for SARS-CoV-2 virus among certain populations to better inform their next steps as they move through this pandemic.
Thank you, Maria. I think we will take the last two questions, one from Tomo Deguchi from Kyodo News. Tomo, can you hear me?
Yes, can you hear me, Fadela?
Yes, perfectly. Go ahead.
Short question on the participants. I believe in February meeting, we had experts or official from Taiwan, but was this the case this time as well? Thank you so much.
Thank you for this question.